Good morning, everyone. So we have an action-packed morning for all of you. We have the 7th annual Sarah V. and Ernest E. Moore Trauma Lectureship. And then we have a distinguished visitor who was invited by the Moore family and our department, Dr. Marty Schreiber, who is a luminary in trauma research. And you'll hear more of an introduction from Dr. Moore in a minute or two. But we also have the 12th Annual Department of Surgery Research Symposium. And I want to thank all the people who submitted talks and were accepted and their mentors and for coming this morning and taking part of this. So by way of introduction of the Moores, Dr. Sarah Van Duzer is really a distinguished internist and has been so in the Denver metro area. She's a sought-after primary care doctor and has worked at many different settings, including the University of Colorado. She's also been a great teacher and is a great teacher and has taught actually my children in medical school who have rotated through. So thank you, Sarah. Dr. Gene Moore is one of the luminaries of coagulopathy research. He did his undergraduate training at Allegheny College, then went to Pitt for medical school, and then U Vermont for residency. He's held tens of millions of dollars of grant funding from the NIH, from the DoD, and from many, many other sources. He's been on the editorial board of many journals and has been at the helm of the Journal of Trauma for many, many years and helped catapult that journal to one of the top journals in that field. You know, if I were to properly go through his CV, we'd be here for another couple of hours, so I'm going to give you the abbreviated version. He's been invited all over the world. He's trained many, many fellows, some of whom are in this room. Many have gone on to leadership positions. He has a building and a center named after him at Denver Health, where he led the Department of Surgery for many, many years and really made it one of the best trauma and critical care centers in the world. He is actually the most, I put down here one of the most, but he's actually the most prolific author in the world. And I know this is an undercount, but I went to PubMed.gov this morning and there were over 1,500 publications. I'm sure there are much, much more, depending on which of your names that we use. So, and with that, I'm going to ask the Moores to come up. Before they come up, they have two sons who are physicians. Hunter, who trained in the Department of Surgery at the University of Colorado and is now in private practice, and Peter in the front row, who's on faculty here at CU in the pulmonary division. Dr. Moores.
Well, thank you very much, Dr. Schulich, for that very generous introduction. And it really is a great pleasure to have Dr. Schreiber join us among an illustrious team here who he knows all well. I want to start out just as we usually do with a little background. And the goal of this lectureship is to inspire basic research in trauma. And I think we all recognize that if we don't make discoveries at the basic level, we are really not ultimately going to improve patient care. Now, regrettably, trauma particularly has suffered over the past 15 years in commitment to fundamental research. This series in Nature really inspired this lectureship, where they drew some parallels to other divisions and departments, and really highlighted the fact that trauma surgeons were the worst to suffer from this diminishing effort in basic research. And a decade later, actually, the dilemma hasn't resolved. In fact, this review indicated there's progressive decline in research, not only basic but translational in all divisions of surgery, but again, most prominent in trauma. Now, the reason for this is multiple, but I'm here to tell you, and most of you would agree, that this is simply a symptom of corporatization of American medicine. And it's astounding what's happened to us over the past 40 years, and particularly the last 20. There's been a marked escalation in administrative forces that have continued to focus on medicine as a business rather than a profession. And I know you are compromised by this and what your ultimate intent would be. But the fact is, this has had a significant impact on our ability to do research. So I really want to emphasize, though, that if you aren't going to go chase mice and rats around, I think that it's really critical for us all as surgeons to commit ourselves to understand basic science, because you're positioned to really catapult the wonderful discoveries to the patient. And we can have wonderful discoveries, but if we don't translate it to the patient, then this will all be squandered. So with that, then I want to make this introduction of our guest, Dr. Marty Schreiber. His academic background is he was born and raised in Cleveland. And naturally, he remains a very loyal Browns fan that we continue to talk about when the season opens up. And we've given a wonderful gift here with his new quarterback. Marty went to the University of Chicago for undergraduate and then Case Western for his medical training. He then did his internship at Madigan Army Medical Center and then residency and trauma critical care fellowship at the University of Washington. Now, one of the notable parts of Dr. Schreiber's history is his military leadership. He began in 1984 and has had a number of leadership positions, including Chief of Surgery at the Joint Task Force in Honduras, Chief of Surgery at 31st Combat Surge Support Hospital, Commander of the Combat Trauma Surgical Team at Ben Taub, at the point at which that served as a model of the civilian military collaboration, Chief of Trauma at the 228th Combat Support Hospital in Iraq. And then finally in 2010, assumed the highlight of his military career. He was the director of the Joint Theater Trauma System, U.S. Central Command in Iraq, and Afghanistan, positioned in Bagram, and thus he was in charge of all the military-related trauma care throughout both those countries during those conflicts. For this, he has I could be here again for an hour describing this. He has received multiple military awards for his outstanding achievement in these various positions. He is also the founder and director of the Army Military Civilian Trauma Training Program at the University of Oregon. He's mentored over 60 fellows and residents and has over 600 publications. Earlier, some of you may have recognized the ROC Consortium that conducted a number of multi-center trials throughout the country, including the hypertonic saline. And of note, he will be editor of the next edition of the trauma textbook. He's international authority on transfusion medicine, and looking forward to his discussion today. He's published innumerable leading articles and is on basically our alphabet literature in trauma, but notably, along with John Holcomb, really led the one-to-one-to-one balanced resuscitation program, and more recently has shown that 2 grams of TXA, not 1 gram, is critical for improvement in traumatic brain injury. He has similarly in this arena achieved a lot of grants from both the DoD and the NIH. Marty and Karen have enjoyed the outdoors in Oregon, and it's a great honor to have them join us. The title of his study will be Whole Blood Through the Generations. Professor and Colonel Schreiber.
Morning, everyone. It's a tremendous honor to be here and a real pleasure. I see a lot of friendly faces in the audience that I know from other places, and it's great to see old friends. I could spend a lot of time talking about the Moores, but you heard from Dr. Schulak about all of their incredible academic advances and the things they've done. I want to talk just a minute about their family. So I spent the weekend with them at their cabin in Steamboat this weekend. I got to meet them, their families, extended families, and the enriching feeling of being part of that family for a weekend was incredible for me. And it's also incredible to see a family that has the capability not only to be great at medicine, but to be great at being a family, and all the love that was shared between each other, their children, their grandchildren, and their dogs, which I got to pretty intimate with in the car on the way back from the airport. I had to wear a different suit because the one I wore has hair all over it. But it was just a real honor and a pleasure to be part of that family for a weekend. And it's also great to be here seeing the friends in the audience that I know. So I'm going to talk about a subject that I'm pretty passionate about, which is whole blood. It's an interesting story. It's a mixed story. It's not a straightforward story. I thought it was when I first used it in Afghanistan, but I know now in this setting, in the civilian setting, that it is not a straightforward setting. But hopefully one day we can get to where we were in Afghanistan and have walking blood banks in our hospitals. And I'll talk a little bit about that. So hemorrhage is the leading cause of preventable death after trauma. If you look at it, it's about 90% of preventable deaths. And, it's interesting, we had ATLS taught us for decades, ABC, right? So we're treating airway while the patients are dying from hemorrhage, which was a mistake. And I think we're going to correct that in the next following issues of ATLS. But we've now recognized that the reason why people die that could live is hemorrhage. So the most important thing about hemorrhage is great surgeons. So there's a lot of great surgeons in this audience as I look out onto it. And what saves the patient is great surgery and great surgical teams and great hospitals that function well from the starting in the out-of-hospital setting into the emergency department, then into the operating room. If that doesn't go well, it doesn't matter what blood product you use. It doesn't matter what other adjuncts you use. You have to have great systems, great surgeons, and there's a lot of them in the audience. So the point of this lecture is when people are hemorrhaging, they're not hemorrhaging crystalloid, they're not hemorrhaging red cells, they're not hemorrhaging plasma, they're hemorrhaging whole blood. So it's pretty clear, and has been for 600 years, that if something's bleeding, we should give whole blood. It just makes sense. And I'll also talk about the future, which I think is very interesting. So this is the pathophysiology of coagulopathy after trauma. This is contributed to a lot by the Moore family. And acute traumatic coagulopathy is something that is endogenous to bleeding. So if you're hit by a train, you have massive tissue injury and you become acidotic, you become coagulopathic. And actually Mitch Cohen, who I don't see in the room here, contributed to this literature quite a bit. And this seems to be related to activation of protein C. And that's endogenous. It happens within minutes. If you draw blood on a trauma victim who's severely injured, they will be coagulopathic within a couple minutes. And that's something that, that is not related to treatment. Now, unfortunately, once patients come to treatment, still in many places, when they're treated, they're going to get normal saline or lactated ringers as an initial resuscitation fluid. Now, this is gradually changing and getting better, but if they do get crystalloid, that fluid is very acidotic. Many people don't realize this, but the pH of saline is about 5.5. It's a moderately strong acid. It's the pH of lactated ringers is in the 6 range. So these are acidotic fluids. They're high chloride containing. They cause acidosis. They cause hypothermia because in the field they're given at room temperature, and they cause hemodilution. There's no coagulation products in them. Even if you give red cells, there's no coagulation products in red cells. They cause coagulopathy. If you give crystalloid, all these horrible things that you see there on the bottom line happen. You get an intense inflammatory response. That's why people were getting ARDS in Vietnam. You get hyperfibrinolysis, the fibrinolytic system is activated. You have endothelial dysfunction. Annika Kaku is sitting in the front row here. Her mother is a worldwide expert. Shabani, who was here last year, talked about that. You have dysfunctional fibrinogen, you have platelet dysfunction. So that's a lot of horrible stuff. Now, the one thing that treats all of this is whole blood, but that's fresh whole blood right out of a person, 100% coagulation activity. It'll treat the acute traumatic coagulopathy and it'll prevent the trauma-induced coagulopathy. So you don't have to get coagulopathic at all. And that's the one thing that does that. So let's talk about the history of it, which I think is actually very, very fascinating. So it starts all the way back in 1665. So a physician in 1665, in this case, Richard Lauer, a British physician working in London, said, you know, it's really obvious. If you exsanguinate a dog, the way to save it is to give it back blood. So he created a blood bank of dog blood. He exsanguinated dogs and then resuscitated them with dog blood, and they all lived. So even back in 1665 was pretty obvious. So in terms of humans, Philip Singh Physic, he was actually from Philadelphia. He trained with John Hunter, who was one of the most amazing surgeons of all time. Actually did the first human transfusion. I'll show you this. This was from a sheep to a person. It was successful in that the person didn't die, but otherwise really didn't have much of an effect. There was actually 2 reported transfusions in the Civil War. And I'll show you that paper, but they were successful. These were both people with extremity injuries who had infections after their initial injuries, who bled secondarily, who were very anemic, got blood, and actually lived. Blood transfusions in the early 1900s were done by vein-to-vein anastomoses, but by Alexis Carrel's technique, which, you know, Alexis Carrel is one of the very few surgeons to get the Nobel Prize for that technique. His technique still used, and that's how transfusions were done in the early 1900s. And then in 1970, something horrible happened. We took apart the whole blood, started making components, started giving people lots of red cells, very little plasma, and lots of crystalloid. And then we had very sick patients that all died. And I was part of that. So this was the first transfusion to a human. This guy was crazy, and they figured if they took a nice, calm lamb and transferred blood out of the calm lamb, he would not be crazy anymore. Well, he survived the transfusion, luckily. First, they exsanguinated him, by the way. He survived. He might have got a little less crazy while he was exsanguinating, but the lamb transfusion didn't do a whole lot to help him. This paper documents the 2 Civil War transfusions. The first person was an enlisted person in the Northern Army who had a injury to his leg and bled, was very anemic, got 16 ounces of blood. The transfusion is really well described. Initially gets tachycardic and tachypneic, but then pulse comes down, color returns, and the guy survives. Second one got only 2 ounces, but also survived and actually did well. So these, obviously there was no typing. They got lucky with the blood transfusions, and these two soldiers survived these transfusions. But most people don't know that we were giving blood in the Civil War, and we weren't messing around with crystalloid. We weren't messing around with red cells or some component. The Civil War surgeons knew they're bleeding whole blood, they need whole blood. So it was really just intrinsically obvious. So what about World War I? So in World War I, they were using crystalloid, and they were using normal saline. And Walter Buchanan published in JAMA in 1918, over 100 years ago, is that we need a fluid that will resuscitate the patient without causing acidosis and all kinds of physiologic abnormalities. So Walter Cannon was a captain in the United States Army, and he was a physiologist at Harvard. And he recognized that we need to give whole blood. This is a paper on whole blood from World War I by Bruce Robertson, who was a captain actually in the Canadian Army. And he recognized that people who were getting whole blood transfusions in World War I were doing very well, and they were surviving. And he gives this credit to Cryle and Carrel, again, and others who were present that were giving whole blood transfusions in World War I and saving lives. Now, World War II was very, very interesting. So I will tell you that the World War II surgeons were ahead of us where we are today. They were doing things that we still want to do. And their primary resuscitation fluid was lyophilized plasma. It was a multi-donor plasma. It came from donors. They weren't checked for any transfusion-transmitted diseases. and lots of people died of hepatitis. And we have not used lyophilized plasma in the United States since that. There's a couple of products. They're not FDA approved. They probably will be soon. But lyophilized plasma was the primary resuscitation for everything. It was the initial resuscitation for hemorrhagic shock until the whole blood arrived, which it ultimately did. But it was also used for resuscitation of burns and traumatic brain injury. And they had a burn formula for lyophilized plasma. For every 10% total body surface area burn, they gave 2 units of lyophilized plasma. And then they checked the hematocrit. And if the patient was hemoconcentrated, they gave more plasma until the hematocrit was normalized. So there's burn surgeons out there who are doing studies on this who think that they're starting this and it's their first idea. The World War II surgeons were doing this, had done this on hundreds of thousands of people. They also recognized that crystalloid, which they did not use, caused brain edema. So they used lyophilized plasma to resuscitate traumatic brain injury. And actually, they described wet lung. So we give the credit to the Vietnam surgeons who came up with Danaan lung and shock lung. But it was actually the World War II surgeons that recognized that ARDS and pulmonary edema was occurring in the World War II war fighters. So we've lost all this information, and it's really kind of distressing. So it's interesting, Edward Churchill, he was a thoracic surgeon for Harvard. He was a surgical consultant for the European theater, and he came into European theater and said, what's going on? We're giving all this plasma. We need to give red cells. The Russians were giving whole blood from cadavers. The British were using whole blood. By the way, if you bring up whole blood from cadavers, you get a real diametrically opposed response. People are violently in favor of it and violently against it. And it's really interesting. We had this conversation at a meeting just a few days ago, and people are really divergent on this. But the Russians routinely used whole blood from cadavers. And basically, the British were using it, the Canadians were using it, we were primarily using lyophilized plasma, and Edward Churchill came in and said, this is crazy talk. Talks to the generals said, you get what you get, here's your lyophilized plasma. And he went to the New York Times and said, the United States is incompetently treating their warfighters, and all of a sudden the whole blood showed up right in time for the invasion of Europe. Now this is really interesting. This is a walking blood bank in England. This is where about half the blood that we used in World War II came from. If you look at the left upper area there, that guy's licking the needle before he sticks it in the patient's arm to get the whole blood donation. The other guys are looking and like, what's going on? Why is he licking the needle? And then you see the dispensary there in England, and then the whole blood was collected. This is cold stored whole blood. It was collected in these glass bottles, distributed in trucks and planes to wherever the main hospitals were. And the numbers are sort of interesting. During World War II, 13 million units of blood were donated by civilians in the United States. 12 million of those units went to making lyophilized plasma. 12 million units lyophilized plasma. Now, the other million went to making, for the most part, liquid cold stored whole blood. And you can see here the numbers, 385,000 units were given to 386,000 patients or warfighters, injured warfighters, who were wounded. That was just the European theater. We focus on the European theater, but there was also an Asian theater where there were equal number of casualties, and there was a Mediterranean theater that had large numbers of casualties. So this is just one of 3 theaters. So 386,000 people got this blood. Half of it actually came from the United States, and half of it came from that dispenser in England that I just showed you where the guy was licking the needle. So if you go on to the war in Vietnam, here's where you start seeing the crystalloid. And large volumes of crystalloid were utilized. It was the first fluid given to injured casualties. And now you start seeing the ARDS, shock lung, and Danaan lung in large numbers that's clinically relevant. However, whole blood transfusion continued. We used liquid cold stored whole blood from the United States and Vietnam, and we also used fresh whole blood from walking blood banks. The blood was shipped from the United States by plane and usually made it there within a few days. And there were noted clotting deficiencies of this whole blood. And this is something that's very important today. I'm going to show you this. But they recognized during the Vietnam War that liquid cold stored whole blood was depleted of platelets. So the stuff that we use here in the civilian world does not have 100% coagulation factors and is particularly deficient in platelets. And you can see basically that they were using FFP, and this is how I was trained. You didn't start giving FFP until you'd given 6 units of red cells. That was the rule. David Livingston is shaking his head because he did the same thing. And you're giving 10, 20, 30, 40 liters of crystalloid. And you'd put a Swan-Ganz catheter in every patient, and you would give them crystalloid until their oxygen delivery increased enough that their oxygen consumption no longer increased, so-called flow independent. I see smiles in the audience because other people did this. And if that didn't get you to flow independence, then you started the dobutamine. So you took a relatively sometimes uninjured patient and made them really sick by what we were doing, and we were not following first do no harm. So this is a shock station in Vietnam. You can see there's a bag of crystalloid at every resuscitation area there, which was initial resuscitation fluid. And the graphs you see here were the estimates of what the platelet count would do if you give liquid cold stored whole blood. And you can see that the actual is pretty close to the observed, and that when you give a lot of liquid cold stored whole blood, you're going to get platelet deficiencies. And that was recognized in the Vietnam War. So where did the crystalloid come from? The crystalloid came from resuscitation, controlled resuscitation research in dogs. And this was done by Carrico, Cannizzaro, and Shires. Carrico and Shires were chairs at the University of Washington. Basically, 30 or 40 people came from Parkland and took over the University of Washington. And the first chair from Parkland was Shires, and then the second one was Carrico. And these guys did these controlled hemorrhagic shock studies in dogs, and what they surmised was there was depletion of fluid in the interstitial space. So what they said is, give the crystalloid till the whole blood comes. But people forgot the whole blood part, and they just gave the crystalloid. And that was the conversion in the 70s. And also blood bankers started wanting to use components. It was economically favorable. And some patients don't need whole blood. So if you're a cancer patient, you have low platelets, you just need platelets. So the optimal blood bank has both whole blood and components as part of them. So then we went through this period where we're doing massive resuscitation with crystalloids and going for flow independence. And then we made the observation, this probably isn't very good because there's all these people with open abdomens and ARDS and renal failure. So we studied it. And this was a study that was really done by Gene's brother, Fred, at UT Houston, where they did a standard resuscitation with massive supernormal resuscitation to flow independence versus a controlled resuscitation with much less fluid. And they found that if you give a lot of fluid, then you have increased abdominal compartment syndrome, multiple organ failure, death, and what we all saw was these Michelin people. They're all swollen and edematous. And we stopped giving the fluid, and the nurses said, where did all the sick people go? And you said, well, we stopped giving the fluid. And they said, but the fluid, we want to give the fluid. We like giving the fluid, but we were able to stop that after all the time. And this is what we saw. You see in the left upper there, that's called brain bowel. That's what we called it. We gave so much fluid, the bowel didn't fit in the abdomen. The patients had abdominal compartment syndrome. They developed these big, giant open abdomens with fistulas. It was a nightmare when you saw these people in clinic. And then we started with these crazy solutions. You see there's a Whitman patch. There's a person standing on either side of the abdomen. A third person grabs the Velcro and pulls as hard as they can while they two push the abdomen together. And this is usually in awake patients, by the way. And you pull the Velcro tight, and eventually you put the tension on the abdomen, and you get the abdomen closed. So we stopped doing the fluid, and we didn't have to do any of this, and there were no more fistulas and open abdomens. It was an amazing thing to see over the career. So Gene mentioned this paper. This is the proper paper. I think this is a really critical paper. This was a paper that randomized patients to 1:1:1 plasma to platelets to red cells versus 1:1:2. And what the study showed was that early survival was improved. So at 3 hours, the patients that got 1:1:1 actually had a higher survival, but at 24 hours and 30 days, there was no difference in survival. And what actually happened was you only did 1:1:1 until the bleeding was stopped, and that was within 3 hours. And then the 1:1:2 group actually got 2:1:1. So they caught up in the 1:1:2 group, and overall survival wasn't different at 24 hours and 30 days. But this study was critical in many ways, not only because of what it showed, but what it taught us was how to do 1:1:1. So we had to change the way we were transfusion patients because we're going to do 1:1:1. So how are we going to do this? Well, what you did was you created these packs. Coolers would come, and the cooler had 1:1:1 plasma platelets to red cells or 1:1:2. So when the study was over, where I work, we just said, well, we'll just keep using the coolers and keep doing the 1-to-1-to-1. And that's how we learned to do it. And so you see, what happened was you had to develop people that would deliver the coolers. So these were these massive transfusion heroes. These guys are really proud, by the way. They would run to the blood bank, bang on the door till they got their blood, and then run back to the patient, give the 1-to-1-to-1, and they're running back and forth, and the blood bank couldn't keep up with these guys. And they were really proud of what they did. And the ones in our hospital that did this were the people that would help move the heavy patients. So we had a team of people that would help move the obese patients, and they wore pagers. And when there was a massive transfusion, they'd come running and bang on the door until they got their blood. So you saw big piles of red cells, equal-sized piles of plasma, and then 1/6 the size pile of platelets there, because apheresis platelets is 6 units of platelets. And then there's the commensurate mandatory 1 unit of crystalloid there, but no longer 30, 40 liters of crystalloid. And this really changed the way we did this. And the other thing we said then is, there's actually conversations. What's the point of taking the blood apart and making 1-to-1-to-1? Let's just keep the blood together. And that's how we got back to whole blood. So that study really got us from 1-to-1-to-1 to whole blood, and that's what happened. So a big important part of this talk is whole blood is not created equally. It is not equivalent, and you need to know what your whole blood is, because it's really important to know what you're giving your patient. There's big differences in it. So what we used in Afghanistan and Iraq was warm, fresh whole blood. You'd be on a large forward operating base with 20,000 soldiers. You'd call for the whole blood. They'd come running to the hospital, line up to give the whole blood, and within an hour, you're holding a bag of blood that's still warm with 100% of everything in it. We don't get that here. So that's warm, fresh whole blood. It's either transfused immediately, or it can be stored up to 8 hours at 22 degrees Celsius. After 8 hours, it has to now be refrigerated. It's still fresh for 24 hours. After that, it's no longer fresh. Then it can be cold stored. And that's what was primarily used in World War II. It's stored at 1 to 6 degrees Celsius, still fresh up to 48 hours. But then after that, it's stored in citrated solutions. And there are different citrated solutions. If there's no adenosine in the citrated solution, it can only be stored 21 days. If you add adenosine, it can be stored 35 days. Some states and some places have adenosine, they store it for 35 days. They don't leukodeplete it. I'm told that at least the blood at Denver General is from the Red Cross. Mike, is it from the Red Cross here? What's that? Is it leukoreduced? So that blood you can store for 21 days and it has reduced platelet counts. So that's really important. So what blood you're using, I think, is critical, and I'll show you data on that. So the first thing when you think about this is how much additive solution is in the blood. If you do 1-to-1-to-1 versus whole blood. Okay, so you have to have citrated solution, anticoagulant that's put in there. And so anticoagulant, that's not so great to give lots of anticoagulant to your patient. If you use 1 unit of whole blood, that's the equivalent of 70 cc's of additive solution. If you do 1-to-1-to-1, that's 210 cc's of additive solution. 3 times as much additive solution if you do plasma, red cells, and platelets. 3 times as much. Okay, you say, well, that's 3 times as much, that's not a big deal. But what if you're given 30, 40 units of blood? Now you're given lots of additive solution. So you have to be aware of that difference between whole blood and components. So these are the data from downrange. This is Nesson was one of my residents at Madigan Army Medical Center, went on to do very well in the military, and now retired. He said, okay, let's look at war casualties. Let's look at the ones who got whole blood versus the one that didn't. So the ones who got fresh whole blood were sicker. They got more transfusions. But actually, when you look at survival and correct for the severity of injury, they were 10 times more likely to live. So the ones that got whole blood corrected for severity of injury were 10 times more likely than the ones that didn't. Again, this is fresh whole blood within an hour of donation with 100% of everything, 10 times more likely to live. So I was downrange. I'm using this product. I'm like, this is the greatest thing on the planet. We got to have this. And I go on this, I spent a lot of my energy trying to get whole blood, finally get it, start giving it. I'm like, wait a minute, this isn't the same stuff. This stuff's cold. And it's not correcting coagulopathy as well. My patients aren't doing as well. And then the light goes off. This isn't the same thing. And I think it's really important. So we started our program in 2018. Our blood comes from the American Red Cross. American Red Cross supplies half the blood in the country. It's all leukoreduced. Okay, it's all leukoreduced. It's low titer. It has low titer antibodies to A and B, less than 200. It's a mixture of Rh positive and Rh negative. And this creates a whole debate about should you give Rh positive blood to Rh negative females, and we'll talk about that. It's leukoreduced with a so-called platelet-sparing filter, and I'll show you what that does. We stored ours up to 14 days in CPD solution. I'll show you what happens to the blood after 14 days. The quality of the blood goes down significantly, so we just, at 14 days, we spun it down and used the red cells so we didn't waste it. And that's a benefit of leukoreduction. And it's stored at 4 degrees Celsius, and it's really easy to use. All of a sudden, you're not making containers with 13 units of stuff in it. Now you're just having 6 units of whole blood. And it's put in the refrigerator, you dump it in the canister, and you take it to the patient, and it's way easier to use. Now, one thing to talk about is I think that a massive transfusion is one of the most complex things we do. I think a massive transfusion needs its own person to manage it. So we use the resource nurse. The resource nurse is the person in the ICU, the trauma ICU, that helps the really busy nurse with the sickest patient. So who's the sickest patient? That's the one getting the massive transfusion. So the resource nurse goes to the operating room with the patient getting the massive transfusion in the operating room. What do? They do tags on the patient every 30 minutes to an hour. They make sure the patient gets calcium after the first 4 units and then checks calciums and other labs every 30 minutes. And they guide the adjunctive therapy based on the tests. They coordinate with the blood bank and they organize and transfuse blood with the Belmont. And they make sure that everybody who's getting a massive transfusion gets tranexamic acid. So if you're the surgeon and you're focused on putting stitches in the hole to save the person's life, you're not going to be able to do all that stuff. If you're the anesthesiologist trying to manage this really sick patient, you can't do all that stuff. You need a person just to do that. Mike, do you have that? Do you have a person just to do that? So let me show you what happens. So this is a massive transfusion without the resource nurse. This is a massive transfusion with the resource nurse. So let me show you again. No resource nurse. So this is indicative of the entire room, right? There's chaos. You know, the sicker the patient is, there's more activity behind the curtain there where the anesthesiologists are, and there's chaos, and this shows you the chaos. But if you have someone to organize the massive transfusion, all of a sudden you bring order to chaos. So this comes from Colorado. This is the protocol we use. So we're doing these tags. Resource nurse is looking at it and says, okay, well, the ACT is high, we're going to give 2 units of FFP. The angle is low, we got to give cryo. The MA is low, we're going to give platelets, and everybody gets TXA. We don't go by any LY30. We just give the TXA to everybody, and we use 2 grams. So here's a nice example. This is a typical Oregonian. Guy just had his coronary artery bypass graft. He's obese. He's 3 weeks post-MI on Plavix riding his motorcycle. So he crashes his motorcycle. He's got a splenic injury. He's endogenously coagulopathic because he's on Plavix and comes in bleeding like stink. We take him right to the operating room, and you see these tags play out in the operating room. So you're looking at the tag as it's happening, and the bottom tag's the first tag, right? And what do you say? It's pencil thin. So within a couple of minutes, you see that pencil thin tag. Patient needs fibrinogen and platelets, gets it right away. 30 minutes later, has a nice normal tag. Spleen comes out, bleeding stops. The guy's back on his motorcycle in 5 days, taking his Plavix. So this is a real modern massive transfusion that I think really it's how it works. So people ask me all the time, what's the maximum amount of whole blood that you can give a patient? The most I gave anyone in Afghanistan was 21 units. The most I gave anyone in Oregon was 44 units. So we had a patient, he was riding his electric wheelchair across the street, got hit by a car, came in with multiple injuries. We gave 44 units of whole blood, lots of adjunctive therapy. He survived and then went on comfort care because he had his life, he didn't really do very well up until that time. But you can give, so the limit on amount of whole blood you can give is whatever you have. And you can argue with me about philosophy, but my philosophy is my focus is on the patient in front of me, not on hypothetical future patients. So if my patient's bleeding to death, I'll give them all the whole blood I've got, try to save that patient, worry about the next patient later, and try to find whole blood from somewhere else if I don't have it. So I want to talk a little bit about literature. and how to read literature. So you'll read a bunch of papers on whole blood, and people will stand there and tell you that whole blood is the greatest thing on earth. And fresh whole blood is the greatest thing on earth, but is the whole blood we use in civilian practice the best thing on earth? If you read this literature, you got to really look at it. Number one, if you look at the component-only groups, they're not 1-to-1-to-1, right? Now, the advantage of whole blood is that you sort of get 1-to-1-to-1 except for platelets automatically. That's nice. But look at the literature. What is the ratio of the blood products in the component-only group? Now, a lot of papers, patients get 1 or 2 units of whole blood and then massive transfusion with components, and they go in the component group. So should someone who gets 1 or 2 units of whole blood and then 30 units of components go in a whole blood group? Well, they do. That's how the literature works. The cohorts are always unbalanced. Not very many patients in the whole blood group, tons of patients in the component groups, and there's really small sample sizes. So here's an example of one of the biggest paper that's ever been written on whole blood. This is over 1,400 patients. Some got whole blood, some got component only. They showed reduced blood use and decreased mortality. But if you look at these survival curves, for whatever reason, patients with very low ISS and people with very high ISS did better if they got components only. So sort of interesting, sort of mixed. The group at Birmingham is doing a lot of good work. So let me just tell you that the TROOP trial is a prospective randomized trial comparing components to whole blood only. So you only get these are massive transfusion patients, randomized to whole blood or components. That's going to be a good study. Data's not out yet. I think they're about halfway through. Now, the LIGHT study, which is a really good study that you guys are part of, is looking at a lot of warfighter relevant research, a lot of randomized trials. But one of their trials that they did was a prospective trial comparing components to whole blood. I'll show you the results of that. And by the way, they're also doing a randomized trial of whole blood in the field as well. So these are the data from whole blood, the LIGHT study. This is about 1,000 patients, most of which actually 600 got whole blood, 427 got components. And the bottom line in this study was there was no difference in survival at 4 hours, 24 hours, or 30 days. So no difference in survival at any of those times, at any of those time points. Now, they did what people do is they said, well, I didn't get a good result. Let's torture the data a little bit. And they said, okay, what happens if you look at really sick patients? And what they showed was as the patients got sicker, then they got more of a benefit from whole blood. So kind of a mixed result study, not really telling you definitively that there's a benefit. So I mentioned earlier that as you store whole blood, its coagulation capacity is reduced. So a lot of this research comes from the Norwegians, a guy named Geir Stradnes. He has a meeting in Norway. It's coming up actually in the next few weeks called Thor. Thor, the god, Viking god, trauma, hemostasis, oxygenation, resuscitation. And this guy is an anesthesiologist, special forces anesthesiologist in Norway. And what he does is he takes all the special forces guys, takes blood off them, and then studies them. So he'll make them read books and then see if they can retain information after donating a unit of blood. He sees how fast they can run, if they get any weaker. Lots of good research on the person. But then when he takes the whole blood out, he studies it. So one of the things he did was he did ROTEMs, repeated ROTEMs on whole blood after it was drawn. And you can see here in the top right, the maximum clot firmness is statistically increased in terms of decreased maximum clot firmness. The strength of the clot, the fibrinogen, the platelet function is reduced at 2 weeks. Similarly with clotting time, that also increases the time it takes for the blood to clot, increases at 2 weeks. So that's why we spun our blood down and turned it into red cells. All of the coagulation parameters deteriorate over time. So we talked about American Red Cross, universally leukodepletes. This is the effect of leukodepletion on your blood. So you can see there on the right, you see the blue bar, that's the platelet count before leukoreduction. Green bar, the platelet count after leukoreduction. So the leukoreduction significantly decreases the platelet count, and then the platelet count drops over time. So whatever's in that bag you're giving, you got to think about this. Is it leukodepleted and how old is it? It makes a big difference. This is similarly looking at maximum amplitude, primarily platelet function. Look at the effect of leukodepletion on the maximum amplitude, and that effect increases over time. Now, here's the next question. Do you use a Belmont infuser? What does the Belmont infuser do? So if you use a Belmont infuser, your people won't put the platelets through there. But there's platelets in whole blood, and then that goes through there. So you have a rule against using platelets, but still you can put your platelet whole blood through this Belmont infuser. So this is a study we did. We took our 14-day-old blood, and we said, what's the platelet count before and after it goes through the Belmont? Okay? And what you see here is the platelet count before going through the Belmont is 75, and the platelet count going through the Belmont after the Belmont is less than 60. That's a significant reduction. And then if you look at the maximum amplitude and the clot strength, those are also decreased at baseline and go down further after the blood goes through the Belmont. So now you've got old leukodepleted blood that went through the Belmont that's really not that great with respect to coagulation, very important. So then we said, okay, let's look at a center that leukodepletes versus a center that doesn't. So the United States military does not leukodeplete at all. The state of Texas, for the most part, doesn't leukodeplete. They don't use the American Red Cross for the most part. So they have 35-day-old, up to 35-day-old non-leukodepleted blood. So here we are at OHSU, we're using this leukodepleted blood. Here we are at BAMC, we're not using it. So we compared our populations, they're a little bit different. Not surprisingly, the BAMC population was younger, more likely to be male, and more likely to have penetrating trauma. So there's some differences there. When we looked at the blood utilization, we gave more blood overall at OHSU. So we gave more whole blood, we gave more platelets, we gave more red cells, more plasma, and more cryoprecipitate. We gave more of everything at OHSU. BAMC gave less. We also had a higher rate of AKI, so more renal failure at OHSU, and we actually had more transfusion-related reactions. So it looked, this is very interesting that despite being more injured, there was no difference in survival. So you guys are using leukodepleted blood, and that's what we used, and it may not be the best stuff. So in our latest study, we said, okay, let's take all those bad things out that I talked about. The component-only group not being balanced, equally matched patients, and only massive transfusion patients. So we're only going to look at that. So a single-center retrospective study over 5 years, only CAP-positive patients, meaning they had to get more than 3 units of blood in an hour to be in the study. Only massive transfusion patients. Only adults. We excluded people who got pre-hospital blood or people with CPR or ED thoracotomy who were moribund. So I'm going to show you kind of extensive data because the other part of reading the literature critically is you have to know where the study was done. Portland is a nonviolent city, and so it's mostly blunt patients. So the data may be different in Colorado. You guys are a little more violent for whatever reason. So these are patients in their 40s, mostly males. They're mostly blunt injury patients, 70%. I bet your numbers would be higher with respect to penetrating. These are real sick patients, ISS of 25, came in with a pretty much normal blood pressure. Their labs were equally matched, not really very remarkable. They came in with elevated lactates, which were similar both in the whole blood and the component-only group. It came in a little bit coagulopathic with INRs of about 1.3, and they came in with normal fibrinogen. So people are wanting to give fibrinogen first. I don't think that's indicated because the patients have normal fibrinogens. So we were successful in looking at this. The whole blood people just got whole blood. The component-only people just got component-only. And if you look at the component-only group, they pretty much got 1 to 1 to 1. So it's really whole blood versus 1 to 1 to 1. Here's the total resuscitation they got. The whole blood people only got whole blood. Component-only people got components. And the only thing that was different here, interestingly, is the component-only group got more crystalloid than the whole blood group. So very interesting. There's no difference in hypocalcemia. Now remember, you're getting more citrate with the components. Interestingly, that didn't affect the calcium. So that was sort of interesting. So what about outcomes? Bottom line, no difference. Survival, it was identical. Either in hospital, 30 days, no difference in survival. The only thing that was different was the whole blood group needed less operations. So the whole blood group got less operations. Is that because they got whole blood? Maybe, maybe not. Okay, so I want to talk about, just move on to regional blood delivery mechanisms. And the best one in the country is in Southwest Texas, centered in San Antonio. And I want to tell you what they did. It's an incredible program. This is a massive area of Southwest Texas. Okay, and they created a program called Heroes. And what they did was they've got dedicated donors, thousands of people who are dedicated donors who give blood about every 90 days. They take this donated whole blood, store it, and they send it to rural areas. And they send it to ambulances, helicopters, and level 4 trauma centers. All throughout that South. I mean, look, Texas is huge. That blue area of Texas, this serves that entire blue area, which is really mostly rural. If that blood isn't used by 14 days, it goes back to San Antonio at the age of 15 days, and almost all of it gets used. So a regional system with these donors. So it's distributed across 2,600 square miles. They call the program Heroes in Arms, and the donors are considered heroes. It's low titer, it's O positive, and it has no leukocyte reduction. It's stored in adenosine and can be stored for 35 days. So they have this reliable donor source. There's social media, they have social events, and people aggressively come and donate blood because they're really excited about it. And it's really, really incredible. They're donating about every 90 days, and when the blood is used, it's resupplied, and they have extremely low wastage rate because they rotate the blood back to the level 1 trauma centers. So there's published literature on this. Don Jenkins, who was an Air Force guy, kind of ran this program and developed it, and he's a great source of information. If you want to develop a program like this, I would recommend talking to him about it. And he looked at outcomes after using pre-hospital whole blood and showed that there was better early survival. So patients were getting out of the emergency department if they got whole blood in the field. And he also showed that they got less blood products later in the hospitalization if they got whole blood in the field. This is a secondary study published a couple of years ago, same group in San Antonio. They compared patients who got whole blood, pre-hospital whole blood, to those who didn't. About 170 patients got pre-hospital whole blood. And similarly, they showed no improvement in mortality, but patients were using less blood products in the hospital. So it's a little bit of an investment. You give the whole blood early, then you use less blood products later. Now, the unfortunate problem is that you can't bill for pre-hospital services. So legislation has just been passed allowing you to bill for pre-hospital services, but right now nobody's paying for it. So the finances of this is really interesting. In Oregon, we said, okay, look, if we can save on blood products and have better survival, the hospitals will pay for the blood, put it on the ambulances. If the ambulance doesn't use it, it goes back to the hospital. If they do use it, then we're going to get a healthier patient. It's worth the investment. Hopefully one day this will be paid for. So next thing I want to talk about is my dream for the future, which is we will have walking blood banks in our hospitals. So I've seen this work downrange, and there's no reason we can't do this in a hospital, in our civilian hospital. So this is how it works. Again, there's these horns all over our forward operating bases. All eligible blood donors come to the hospital, they come to the hospital. So how many people are working in your hospital at any given time? There's thousands of people in the hospital, right? So why couldn't these people be pre-screened? And why couldn't they come and donate blood when you run out of platelets or you run out of a blood product and the choice is death for the patient or whole blood from the people in the hospital? I mean, if the choice is death, that's probably not a good option. So how are you doing this? You have to triage the donors. The optimal donor has been screened within 90 days, and you screen them for all transfusion-transmitted disease. So we could all get screened, and we could all be eligible donors for the next person who's bleeding to death in this hospital. To me, it's a great idea. Next, you have a history of pre-screening, no pre-screening, but everybody gets this questionnaire. Are you a high-risk person? What are your exposures, et cetera? So when you come and you donate the blood, what do? This is how you do it. You check the person's vital signs. Do they have a fever? Are they hypotensive? Check their hemoglobin, make sure they're not anemic. Confirm their blood type and RH type. All this can be done in a couple minutes. And then there's rapid tests that exist for HIV, Hep B, Hep C, syphilis, and malaria. The rapid tests are right now 85% sensitive. Okay, so low-risk population, 85% sensitive tests, it's going to be pretty low risk of transmitting a disease. Now, again, the choice is death or this whole blood. You know what? I'll take the whole blood. You can treat me for HIV. You can treat me for Hep C. It's okay. And then what you do is you send an aliquot to a licensed lab and check, do they have any transfusion-transmitted disease? If the patient lives, then you can treat them for that transfusion-transmitted disease. I think that's pretty reasonable. Now, fresh whole blood is not FDA approved, and that's the problem in civilian hospitals. How do you collect it? Use standard blood collection bags, big needle, 16 gauge needle, and you use a tourniquet optimally placed to 40 to 60 millimeters of mercury. That's a venous tourniquet, and that increases venous flow. What happened in Afghanistan a few times, they put the tourniquet up too high. Now you have an arterial tourniquet, and you don't get any blood out. And that doesn't work so well. The problem I was involved in one of these situations where we had an accidental shooting on the range, and it was the medics that did the blood collections that were on the range. And so when the guy came in that was accidentally shot, our units of whole blood only had a few cc's in them because they were putting the tourniquets up too high. So you have to have experienced people do this. And you can only take the blood for an hour. So you have to document how long it took. This is what it looks like. Look pretty simple. This is what the patient gets. This is a patient I took care of on election day in Afghanistan. You can see you got 1-to-1 red cells and FFP. This was in a tent with no platelets because platelets can only be stored for 5 days. So you don't see any platelets. It got 2 units of cryo and 21 soldiers donated whole blood so this guy could live. So you see his transfusion on the left side. That's his op report, small bowel resection, splenectomy, distal pancreatectomy, and nephrectomy, and has 4 towels in his abdomen. And this guy lived at least to get to the Afghan hospital, and after that, I don't know what happened to him. So why don't we do fresh whole blood transfusions in the hospital? Number one problem is transfusion-transmitted diseases. There's always an incidence for clerical errors, and this is sort of interesting. We use type O blood, which is universal donor. If we use type A blood and then do type specific, we can increase the donor pool by 40%, which that can be important. We worry about trolley, so women who have been pregnant can have HLA antibodies, which can attack the lungs and cause ARDS essentially. And then there's the risk of RHL immunization with a risk of hemolytic disease of the newborn. This risk is exceedingly low. I'll show you those data. And then the other risk is graft versus host disease. The donor's white cells attack the recipient. Okay, so how often does any of this happen? 10,000 fresh whole blood transfusions in Afghanistan, 1 hepatitis C transmission, 1 HIV seroconversion, 1 fatal case of graft versus host disease. There were additional cases in vaccinated patients who died of their wounds who bled to death. That's a pretty low risk when you have a 10 times greater benefit of survival. So I would argue that we should do this in our hospitals. Okay, so how do you do it? So let's go back to our friends in Norway who set up a walking blood bank in their hospital. And this is a case report, happened in Bergen. They have very cold water like you do in your streams. I can verify that the water in your stream is very, very cold. They have pretty cold water in Norway as well in their fjords. At the store meeting, you have to jump in the water or you can't go to the meeting. So they set up a fresh whole blood donor program. They had fresh whole blood in people in the neighborhood of the hospital. They were screened. And here's an example of a patient that comes in. So the patient comes in, massively injured, multiple pelvic injuries, all kinds of bleeding. And here's how their transfusion went. So at time 0, you see the blue line there. That's the liquid cold stored whole blood. So they give the patient all of their liquid cold stored whole blood, and you can see that gets to 10 units. As they're running out of the liquid cold stored whole blood, they're calling the fresh whole blood donors. Now they start a 1-to-1-to-1 transfusion. You see those yellow red lines. They're giving, at 2 hours, they're starting 1-to-1-to-1. And they're giving all of that, and they give about 70 units of red cells and plasma. While they're giving all the red cells and plasma, now you see the next light blue line, and that's the fresh whole blood donors. Fresh whole blood donors show up, start giving the fresh whole blood, and you can see they gave about 20 units of fresh whole blood. So this is a functional blood bank that uses whatever they have. They run out of whatever, they run out of their bank stuff, call in the fresh whole blood donors. Only option is death for that patient. And they start, and they're able to functionally give fresh whole blood. And they do this on a routine basis. I don't know why we can't do that. So what are some future possibilities? So the biggest issues are transfusion-transmitted diseases and compatibility. If we can address those issues, then we can have walking blood banks. So the first way to do that is, what if we had 100% sensitive rapid tests? So you dip the blood, it either turns positive or negative. It's negative, it has no pathogens in it, and you can give it safely. That could be an FDA-approved product. There's ways to do this with pathogen reduction filters or light. We can already do this for platelets and plasma. We haven't developed the technology for whole blood, but we will, and it is going to happen. And that's being tested in whole blood now. If we add type-specific A to our low-titer O blood universal donor, we can increase the donor pool by 40%. And that clinical practice guideline is being written by the military, and that's going to happen. And then finally, if you can take the antigens off, if you can genetically produce red cells that don't have any antigen in it, all of the whole blood can be universal donor. And I think this will happen one day, and they're trying to do this. So what about the thing that gives people the most heartburn? Giving Rh positive blood to women of childbearing age. So this got really interesting. Centers were saying we shouldn't do this because of the potential for fetal demise. And if you think about it, it's a little, you're withholding a life-saving therapy from an important part of our population, women of childbearing age. It's probably not a good idea, right? So what is the real risk of this? And we went back and we looked at this in one of the LIGHT study, the prospective study that compared whole blood to components. So we went back and looked at this and what happened over time. And this was a survey study that was done by one of my fellows. So 1,000 patients were studied in the SWOT study. I showed you the data from that earlier. If you looked at 1,000 patients getting whole blood, about 130 of them were women of childbearing age. 130 of them. And then as you go down through, if you focus on the females less than 50, you can see the numbers get really small really fast. And really, when you get to the bottom of this, only 13 of the patients were females of childbearing age that were Rh negative. Very small part of the population, and those patients got Rh positive blood. Okay, and that was in the component-only group and also in the group that got whole blood. If you look at those 13 patients, to date, none of them have had a complication from getting the Rh positive blood. So 0 complications, very small risk. And what happened was, you can see the solid black line there, women less than 50, when we started the study, we weren't giving Rh positive blood to Rh negative women, but over the course of the study, we started giving Rh positive blood to Rh negative women. And I think that should be the standard of care. We should not withhold a life-saving therapy for a hypothetical risk that is very rare. So bottom line of this talk is, if you compare whole blood to wine, right? So we all know about wine, right? When we put a bottle of red wine in front of a person, they're going to say, what is the quality of the wine, right? So the best wine that I could find in the world, at least the most expensive, was Domaine Leroy Musigny Grand Cru of France, $75,000 bottle of wine. Most people are going to agree, I want that bottle of wine. So that's equivalent to a universal bag of fresh whole blood that's still warm. That's the best wine, okay? Still warm, fresh whole blood. Now, if you got a 35-day-old bag of leukodepleted whole blood that's cold and depleted of all coagulation factors, that's essentially $3 chuck. So the question is, what wine are you giving? And it makes a huge difference. And people don't really think about this. But if you have the experience of giving the best wine, then you know what the worst wine is. So it's sort of interesting. When we were in Afghanistan, we were putting blood products in medics' backpacks. And the blood products that were in the medic's backpack in 2014 were low titer O whole blood, dried plasma, just like World War II, and cold platelets. You can store platelets cold up to 21 days, and they probably work better than room temperature platelets. So this blood bank in that guy's backpack was probably better than a lot of level 1 trauma centers. And they would carry this into the field and give blood transfusion to austere conditions. What are we going to do in the future? We're going to turn the whole blood into powders. And it can be PCC, dried plasma, fibrinogen concentrate, dried platelets. There's several dried platelet technologies. The one that's the weakest is the oxygen carrier. We haven't figured out the hemoglobin substitutes, but I think we will. And this guy's now going to carry all these powders in his backpack, He's going to be able to resuscitate a lot more patients, which is going to be really important because the drones are flying around and you can't evacuate patients and you can't deliver blood products except by drone. So we're going to have local blood banks in these situations. So that's all I have. It's been a tremendous honor. I'm really looking forward to the resident competition and seeing all the research that's going on. And if we have time, I'd be really happy to answer questions. Thank you.
Thank you very much.
Thank you.
That was great.
Thank you.
Any questions or comments? I think we have time for one because we're a little bit over time.
Thanks so much for a great talk, clearly showing huge. So when we look at the blood banking issue, it seems like a lot of this revolves around how we store the blood, how we collect the blood, how we distribute the blood to people in different parts of the pre-hospital. Some strategies that we can use to help go from the $2 chuck up to the $75,000.
It's $3 chuck there.
Yeah, the price has gone up. So, I mean, it's interesting, us trauma, the people that do what we do, general and trauma surgeons, we're sort of becoming hematologists. And I really think the most important thing is you have to have a good relationship with your blood bankers. So there's really 3 levels. The first level is where does the blood come from? And some institutions actually get their own blood. So Stanford has their own blood bank. So if you do that, you can do whatever you want with it. But the blood has to come from somewhere. If you isolate yourself from getting it from the American Red Cross, you're going to get leukodepleted blood. So you've got to open the conversation up with your blood bankers and say, look, we don't want leukodepleted blood. We want blood from another source that's not leukodepleted, that's stored in adenosine. We can store it for 35 days. They'll like that. They'll want to be able to store it for 35 days. And you can make the argument that it's a better product. So I think that, you've got to have the conversation with your blood bankers. It's up to your blood bankers. They have contracts with the American Red Cross for X numbers of units. So that you have to have that conversation that, bring people from the American Red Cross to your meetings, have these discussions with them, talk about quality of blood. And I think most reasonable people are going to come to the conclusion that they should be looking at other sources. In general, you should have multiple sources for your blood because any one source can run out. So what do you do when they run out? You have to have other sources. So this is a conversation that, a person like yourself who's educated, speaks on their level, respectfully says, hey, look, can we look at another source of blood that's not the American Red Cross, that doesn't leukodeplete? Oh, by the way, you can get non-leukodepleted blood from the American Red Cross. They'll charge you $500 more not to leukodeplete it because that's what they do around the countries. But this is a conversation with your blood bankers. And those are the 3 levels: source of blood, blood bank, and then delivery. And you have to have those conversations. I mean, what we did was we would talk about every massive transfusion, and the blood bankers would come and we talk about what we did well, what we did poorly. They understood what was going on. They understood the coagulopathy, and they wanted to give the best product. That's how I would handle it.
Okay. So I just have one final comment. It seems like it's not about the risk. It's not about the science. It's all about the logistics. And the person that conquers the logistics, the system that conquers the logistics, gives greater benefit to their patients.
Yeah, I couldn't agree more.
Yeah.
Absolutely.
Great. Well, again, thank you very much.